So when I received this invitation from the society, inviting to a 50th anniversary to a 500-year-old institution discussing past, present, and future, I did not know exactly what to expect, but as a pediatrician, I thought I need to pay my courtesy and acknowledge this guy who 130 years ago described the condition what we today know is celiac disease, just a hospital nearby. And yes, sorry, we had a discussion. I'm not sure it was at Great Ormond or it was at St. Bartholomew. Yes, yeah. Okay. So anyhow, rest is history, and what he probably met at that time point was children with severe malabsorption syndromes. And I would today consider this as a rare disease, at least at my unit in Sweden, where we meet a lot of children with celiac disease. We're a highly prevalent country. We also see geographical differences between the south and north of Sweden. But at my unit, I would say that almost one kid in every school class has celiac disease at the time point. And I think that is quite disappointing. And if I would go back to Samuel G., I would say, what have you done? We have diagnosed a lot of children, but we don't know what to do. We can't prevent the disease. I think that's a failure. So, but the society want me to discuss the ongoing prospective study called TEDDY. And the reason for, I think these studies are important because I'm looking for triggers. And if we're looking for triggers, we want to collect data prior to disease onset. And there are quite a few studies that has been gone on for a while, and some of these old birth cohorts actually now are adults. That started in the late 80s in the German baby diet study, the Colorado study DAISY, and the Finnish study DIP. They've been following these children for a long time now. And most of these studies are prospective studies on type 1 diabetes. And we also have the CPCs from my department, and in 2004 we merged all these cohorts and started a new study called TEDDY study, and then we have the intervention study, CEDAPREV and Prevent CD, that you may have heard of. So the TEDDY study is an environmental determinant of diabetes in the young study. It's the original purpose of this study is to look for environmental triggers for type 1 diabetes, but this is also developed to become a celiac disease study. So the overall goal is to identify environmental and genetic factors that associate with type 1 diabetes and now also celiac disease in 2006, and now also thyroid disease since 2 years ago. So the design, this is an observational multi-center study with a 15-year follow-up located at 6 clinical centers in Finland, Germany, Sweden, Colorado, Georgia, and Washington State, and the US, and we have a data coordinating center here in Tampa that runs all the analysis. So the population is an HLA risk population, the children that are selected from the general population and from first-degree relatives with type 1 diabetes, and they are followed from birth to 15 years of age. And the enrollment of these initially selected 8,667 newborns were screened from the general population. We screened almost 425,000 children at these sites. And among those, most of them were selected from the general population. And from the German side, we had quite a few with first-degree relatives with type 1 diabetes. And of those, we had 21,000 approximately that had the high-risk genotypes of interest, which is mainly the DQ2, DQ8, DQ28, DQ22, which is of interest of type 1 diabetes, but of course for celiac disease as well. And among those 8,667 accepted participation to this very ambitious follow-up for 15 years of age. 15 years. Every site follows the same protocol, and I think that's very crucial for this study. It's very, very, very ambitious and laborsome. We have these clinical nurses and clinical sites that collects blood samples, stool samples, nail clips, urine samples, questionnaires on diet every 3 to 6 months and onward. And the retention rate currently now at 13 years of age is approximately 70%. So we kind of succeed to keep them in the study, which is really, really important This is an NIH-funded study, which costs a lot of money, and we really need to have the follow-up to get all the number of cases in order to make very good case control studies in the end. So we started in 2004, we are halfway there, and the end station is in 2025. So we did just a summary for you to just know how big this study is, that we completed 160,000 visits. We have 600,000, this was last year, completed questionnaires on diet, vaccinations, infections, whatever. And 3.5 million blood samples. We got a lot of poop in Washington, D.C. now. Stored at the repository outside Washington, D.C. And currently we have approximately 500 cases with biopsy-proven celiac disease at the time being. So we set up the goal to study two outcomes, mainly. The first outcome is celiac disease autoimmunity, which we define as 2 consecutive samples positive for tissue transglutaminase autoantibodies. And the second outcome is to have biopsy-proven celiac disease. We want to keep these separate because not all children with tissue transglutaminase autoantibodies develop celiac disease. But we also wanted to keep a strict definition, but we wanted to have this definition because we know at the time point where they seroconvert within the 3-month limit. If we want to look at triggers, we want to be sure that it's before they develop the tissue transglutaminase autoantibodies. So we often present in our papers both outcomes. So we set up the ambition to study all these factors that has been associated or previously thought were triggers for celiac disease. For instance, if in pediatrics, we talk about infant feeding a lot. If breastfeeding is associated with protective or not, if the gluten intake, when the child is introduced to gluten during the first year of life, etc. Maternal diet during pregnancy, vitamin D deficiency, or infectious episodes, the vaccination status, etc., etc., etc. And for this study, I tried to just give some results of the gluten intake because I think that is important, as previously indicated from India, and also mode of delivery and infectious episodes. So what is really striking is the fact, and this is a known finding, if you follow the children over time on the x-axis, and you see the proportion of those who develop celiac disease autoimmunity, we see a clear gene dose effect of HLA. If you have 2 HLA DQ2, you are in deep risk. Sorry. Almost 40% of them develop celiac disease, and the DQ2 are prevalent among 1.5% in the general population. But that's a really high risk gene. And then you see the gene dose effect. If you have one DQ2 haplotype, you have less risk, but you are at a greater risk than if you have a DQ2, a DQ8 or DQ88, etc. What was also striking from this study is that we see country differences. Sweden has always been considered as a risk country, where we have young children developing celiac disease earlier. We've known that for decades. We don't know the reason. But this is shown for the first time in a multi-center study that the Swedish children develop celiac disease at an earlier age, by 36 months of age, as compared to the US children. So you think that, okay, maybe they have another genotype. Well, it's not true, because if we take only those with the DQ2, and look for the country differences, you still see the difference. The Swedes develop celiac disease earlier than the others, pointing to the direction that there could be environmental factors involved, or other genes. So this is what we want to study. So what about gluten? We have been discussing gluten for decades. Is this a trigger in early celiac disease? And looking at the different country differences of when you introduce gluten in Finland, Sweden, Germany, and the US, it is quite striking that 95% of the Swedish kids have been exposed to gluten by 6 months of age. compared to 54% in in Finland, and 34% in Germany and in the US. So there are huge differences when you introduce gluten to infants in the countries. So we thought that the age of gluten introduction could be a trigger when you develop celiac disease earlier. But it's not true. If you look at the known risk factors so far, if you go to the right, the farther to the right, the higher the risk. If it's 1 point, there's no risk, and if it's below 1, and it's a protective effect. So the highest risk is associated with the DQ2. The second highest risk factor is having a first-degree relative. We know that these are found among families, right? And the second is being a female. Females are a twofold increased risk as compared to males. You know all this. You've seen this at your sites. But looking at the introduction to early or late, it doesn't show any effect. It's not associated. And this was actually also in the systemic review afterwards from other prospective studies also concluded that neither breastfeeding nor time to gluten introduction have no effect on the risk of developing celiac disease during early childhood. So what about the gluten consumption? It's very different from how much gluten you give the children. The gluten amount has been discussing for ages, but it's very difficult. How can you measure the gluten amount in a study if you don't do it prospectively? So this is from the Prevent CD study from 5 different countries in Europe, and you see huge differences in the mean daily intake of gluten per day. But the conclusion from this study is, and I'd probably say it's probably underpowered. There was no association between high intake of gluten and increased risk of celiac disease after 11 months of age. However, we did a sub-study of the Swedish TEDdy cohort, where we picked 146 cases with celiac disease, and we matched them with 3 controls per every case for HLA, gender, and age. And we followed them and took the diet records before 2 years of age, prospectively collected before they developed celiac disease, and we found the following. At 12 months of age, the cases eat much more gluten compared to the controls. And this is true also at 18 months of age, but not at 24 months of age. So the cases eat in Sweden high amount of gluten compared to their matched controls. And if you stratify this eating gluten less, moderately, or high amount, you see that the children that reported high amount develop celiac disease at a higher extent and also earlier. So the conclusion is, at least in Sweden, the high intake of gluten before 2 years of age seems to be a trigger for pediatric celiac disease. And we need to confirm this now in ongoing studies for all the TEDdy study. What about infections? There have been indications, just recently, last year, there was a paper in Science that maybe a non-virulent virus called reovirus could be a trigger, at least in a in vitro model, I think it was. But the study from Norway, the Norwegian mother-child cohort study, is a huge study, which mainly on questionnaires where they have reported, where they have included 73,000 children between 2000 and 2009, and they collected all those prospective reports from the parents about the infections, and they saw that having gastroenteritis was not that associated. Very small effect of the lower respiratory tract infection. But if you add the number of infections, you see a pattern. For those who report 9 or more infections prior to onset of celiac disease, those are at higher risk compared to those who only report 4 infections. So then you say, okay, so it's a symptom of celiac disease, all right? Well, we checked it also, but the conclusion was that the early infections may have a role in celiac disease. So we wanted to check this also in the TEDdy study, and we collected almost 14,000 gastrointestinal infectious episodes between 1 and 4 years of age, and almost 80,000 respiratory infectious episodes, and we saw a really interesting finding. The finding was that there was no association for the respiratory episodes. But for the gastrointestinal episode, there was those who reported an infection 3 months prior to serum conversion, they were associated with having a risk for celiac disease later in life. And then you say, okay, that's only a symptom of celiac disease that the parents report. But the interesting thing that this was highly associated with seasonal birth when the child was born. It was a seasonal effect. So we have this, so the conclusion was that at least in the TED study, we see that the gastrointestinal infection increased the risk of celiac disease autoimmunity. But we went further. So we have the data on the rotavirus vaccination coverage by country and state in TEDdy. And it's interesting because when we started to enroll patients in 2006, only 24% of the US kids had a rotavirus vaccination. And the same situation was in Finland and also in Germany. In Sweden, we don't do that. It's been an ongoing discussion forever. We haven't vaccinated. So we thought maybe that's the reason why the Swedish kids are at increased risk for celiac disease, because they have been exposed to rotavirus vaccination. So we saw some really interesting finding. In older children, there was no effect. But in children younger than 2 years of age, those who were vaccinated against rotavirus vaccination were protected to be developing celiac disease. But what is more interesting is what we see in this graph. I'm trying to explain this. Is that we did some interaction analysis of when you eat gluten, when you're vaccinated or not. And these are mainly from the US and the Finnish children. If you're introduced to gluten after 6 months of age and you have a vaccination or not, there's no difference. But if you give the child gluten before 6 months of age and you're vaccinated against rotavirus or not, you see the difference. There's increased risk of developing celiac disease if you're not vaccinated, if you give gluten before 6 months of age. So the conclusion from this paper is that it could be an indication that there is a virus, or maybe many viruses, that could trigger celiac disease in early pediatric celiac disease, which could be modified with gluten or the diet. What about mode of delivery? There's been an ongoing discussion with other chronic diseases that if you're delivered by C-section or cesarean section, you will change the microbiome in the infant, and it's been associated with many chronic diseases like IBD, etc. And it's been a discussion also because the results are a bit contradictory when it comes to celiac disease. This is a paper from my dear colleagues in Sweden, where they had access to pregnancy data from the Swedish Medical Birth Register, and so Jonas Ludvigsson and co-workers, so he collected the pregnancy data between 1973 and 2008 from almost 12,000 offspring that developed celiac disease, and from our patient register we were able to collect a huge number of selected matched controls, and in this case he selected almost 54,000 matched controls from the general population. And what they saw that there was no increased risk of celiac disease after emergency C-section, but an elective C-section was associated with a minor risk. So the conclusion from this study was that maybe the bacterial flora of the newborn plays a role in developing celiac disease later in life. So we did the same thing, copy and paste, but in the TED study. So we included 6,000 singletons. 26% of them were born by C-section, and 74 by normally vaginally delivery. And we had, in this case, we had 343 cases with that developed celiac disease. We saw no association whatsoever. It was actually that those who were delivered with C-section developed celiac disease later as compared to those who delivered normally. So we did not see any association. And we recently published the same thing on antibiotics. We saw no association whatsoever. So there are differences between doing studies on patient register where you don't know clinical background of HLA and all those that could be biased the whole study. But the conclusion from TED is that the C-section does not increase the risk of celiac disease. So a summary from the TED study this far is that if you list all those potential risk factors that we know today, when you stratify them at the high risk, and in this forest plot, one is no risk, and if you're on that side, you have a risk, and if you are below one, the factor is protective. The absolute number one is being DQ2, DO33, the same. Having a second, only one is the second highest risk factor. Having a firstly relative, we all know this. These are known risk factors. We need to find out what is going on in Sweden. We have a lot of, that's a strange country up in the north, strange people. I hear that all the time. In Teddy, when we started, they call us for biological artifacts. They didn't believe us. So we have all these SNPs from the GWAS studies that we can confirm that are associated with risk of celiac disease. And then we see the gluten amount. And I have left this out because we have promising results we hope to publish this year from the whole TED study of over 60,000 food diaries that will shed light on the gluten amount mystery. And we know that born in the spring is associated with having a gastrointestinal infection, breastfeeding. Well, if you breastfeed for longer, it's associated with increased risk. I don't want to talk about that. But not the mode of when you introduce, but also you see the protective effect of rota vaccination under 2 years of age, and if you're introduced to less than 6 months of age. So this changes the map a bit. Many of the risk factors that we know today, we cannot find. I think that is important, that negative findings from TEDdy is really important, that we kind of focus now on majorly 3 things. Genes, gluten intake, where you live, and if you're exposed to infections. So that comes from a take-home message for you from TEDdy so far, that there is a role of HLA, no doubt about it, that genes play a really strong role in developing celiac disease, and maybe not only in Sweden, but also worldwide, in India or China, whatever. HLA is really a strong determinant for celiac disease. Other determinants are the female gender having, and we all know this. The role of the diet, it's a bit controversial. Time to first introduction, no, that does not seem to play any role in celiac disease, but the amount probably will, at least for pediatric celiac disease. We need to confirm this, and more to come from TEDdy. Role of infections. Early life infection may play a role, especially if it's a gastrointestinal infection. The frequency of infections, the number of infections seem to also be a trigger. But the protective effect of rotavirus vaccination needs also to be, points the direction that maybe a virus could be involved. And role of the mode of delivery as a proxy for change in microbiome. We cannot confirm previous finding that mode of delivery is associated, because there is a risk of the bias in the registered studies. So to be just short, brief, I'm just over, is that the celiac cocktail, what I believe, to make it simple, infections, gluten, and genes, the flavors in the cup, right? And on top of that, something that sparks, and you have this celiac cocktail. And I think that is what we need to find out. And I think that the importance of prospective studies is that we have the possibility to study the interaction, because we have the biological and the information data prior to diagnosis. And happy anniversary from the TEDdy study group. Thank you.
That was excellent. Thank you very much, Daniel. So a couple of questions for Daniel. Max, there's a microphone just coming to you there.
A few years back, there was this epidemic of childhood celiac disease in Sweden, which was linked to a change in the formula. How does that fit in with what you found in the TEDdy study so far?
Well, it fits in quite well. What he's talking about is in the mid-80s, we saw a lot of sick children with absolutely malabsorptive syndromes that developed celiac disease at a very early age. And that happened when they postponed the introduction from 4 to 6 months. And what I have not discussed here with you today is that we give the babies and infant, by tradition, a very special formula called gruel, which is a very highly content of gluten. You know, every time I say gruel to people from outside Scandinavia, it's like, what? And it's been ongoing, and after that, they saw this epidemic of very young children developing. And at the same time, the company making these gruels, the content of gluten in those baby formula was increased a lot. So they received a very high dose of gluten-containing diet during the first 6 months of age, at a very, very steep increase from 6 months to 7 months of age. And so I think that fits with what we see from the children that by 9 to 12 months of age, we see that the cases have a higher intake of gluten compared to the controls. But we need to confirm this, because I told you Sweden is a different or strange country in many ways. We need to confirm this in the host TED study, and we have a promising data.
I'll take one question. That hand went first of all.
Hi, Mark Furman, Royal Free. You've spoken about celiac disease and gluten exposure. Has there been any analysis on the rates of diabetes and gluten exposure or celiac diagnosis in your preliminary analysis?
So we are currently running that analysis as well, because it's difficult to get the data immediately, because you must imagine that we have 600,000 questionnaires on food data. We need to harmonize those so that one portion of spaghetti pasta is the same in Germany as in Colorado. So that's been a laborsome work that we standardize and harmonize the data, and that's been done now. We look at the two outcomes, celiac disease and type 1 diabetes as well, on gluten intake.